to introduce Dr. Jean-Michel Arnal, who is part of the anesthesiology and an intensive care unit. And most importantly, he is in charge of the Centre for Home Mechanical Ventilation at the Hospital Saint-Mus in Toulon in France. He's also organizer of Les Ateliers de Ventilation à Domicile. And rather than me tell you a little bit about his practice, Jean-Michel, would you mind just telling us a little bit about where you work and what you do?
Thank you, Michelle. Very nice to talk to you. So I'm an anesthesiologist by background, and I work in a 20-beds ICU. And this is part of my time. The other part, I'm taking care of a home ventilation unit that follow around 200 patients ventilated at home. Most of these patients are patients equipped after ICU exacerbation or exacerbation in the ICU, and that we equip with an IV.
Fantastic. And I think that the COVID pandemic has made us change our practice. And I am sure that you were remote monitoring your patients prior to this anyway, and I know that you have lots of experience in this area. Can you just explain to me how you use remote monitoring in your everyday practice?
Actually, we try every time it's possible to connect the ventilator to remote monitoring system. So today maybe 110 patients are followed. And what I do is I don't do it myself on a daily basis. We work with caregivers, with home care providers that we look into the data of the patient on a weekly basis, usually Monday morning. They check their patient, and if they see something abnormal, so we have some protocol, they have to follow the protocol. If there is something wrong, they call the patient and they try to solve the problem. And if they are not able to solve the problem, let's say on Wednesday or Thursday, then they would call me and inform me. And the very good point about this is that I know that they do it very well. They call the patient quite often, but it's very unusual that they need my support. Meaning that all of the problems that they are tracking are simple problems, leaks, daily use, remotivation of the patient, meaning they don't need a physician to take care of this.
So if a centre was starting up remote monitoring, you've explained to us that the home care provider is able to solve a lot of problems with basic monitoring. What basic monitoring would you say is essential when starting a service? Would it be something as simple as leak, compliance, residual AHI, and hours of usage?
Yeah, exactly. That's very simple variables. You know, first of all, the risk is to be overloaded with a lot of data that we are not able to interpret. So I prefer to focus on 3 variables: daily usage, but also the graph of the daily usage, how the patient uses it. Is there some fragmentation or not? Then leaks, as you said, this is of course very important. It's problem number 1 in an IV at home, but also the leak shape along the night, because if you know that there are some leaks, you never know what is the cause of the leak. Then you look at the leak shape over the night, and sometimes you can guess if it's due to the mask or due to a malposition of the mask or whatever, so you can help the patient. And the third parameters, as you said, is the index of apnea, hypopnea, but we all know that this index is not very accurate, so there are limitations in this index.
And so by the time if there is a patient you have to review, do you find that at that point you like to have some ventilator downloaded information, or would you normally just have a discussion with the patient and see where you are before you look at the full flow pressure curves and other information that some remote monitoring systems can give you?
Well, to be honest, most of the time when I'm called, it's because the patient has some kind of exacerbation. So it's not a matter of ventilation, it's that the patient deteriorates, and then he needs to see a doctor.
Perfect. And I know in France that the system is different to other countries. Is there a good sort of remuneration for remote monitoring built into the billing and remuneration system?
This is under testing. So there is a program in France run by the Ministry of Health that is assessing if remote monitoring is useful and how we can pay for it. And for this, we have remote monitoring that we must look on a daily basis, except the weekend. But they force us, somebody, to check the data on a daily basis. So it's quite cumbersome, to be honest. And of course, there are a lot. We use also an alarm system, so an automatic alarm system on the daily usage and so on. And for the moment, it's not working very well, meaning that we have a lot of false alarms. But we are not able for the moment to find the appropriate alarms.
Okay, so it's almost like for the future that we need an artificial intelligence built in, or that we can adapt those parameters to prevent unwanted alarms that aren't needed.
Absolutely, absolutely. And I'm working on this for now almost 2 years, trying to find appropriate alarms for an individual patient. And to be honest, I don't know how to do this. So, as you said, I think artificial intelligence is needed.
It is difficult. When you send patients home, is there a particular diagnostic group that you always think, well, they're going to do well with remote monitoring? I'm pleased that I've set them up, or would you say it's very much dependent on the severity of the patient?
Well, both. I would say every patient that we send home, it's very difficult for me to predict if they will use the device or drop it. So I like that all the patients that we send home are remotely monitored. I think it's very important the first weeks to follow them, quite precisely. Then when they get used to it, of course, the most severe patients are the ones that benefit the most.
And just for the viewers to this recording that we're doing now, do you have a particular memory or a patient that has taught you something or about remote monitoring that you've thought, I'm so pleased I gave that to you, or that there's a lesson we can learn from any of the patients that you've looked after?
Well, my first motivation came from a patient. It was a lady with an overlap syndrome that was admitted in the ICU, educated on an IV, sent back home. After 1 month, she was okay. Then I saw her after 3 months and she was absolutely perfect. The blood gas was perfect, the daily usage was perfect. And I told her, that's great, please keep going, that's great. And what she heard is that I'm fine, so I don't need my NIV anymore. And she stopped right away to use it. And 2 weeks later, she was again in the ICU. And I realized, wow, I should have known that she dropped the device. And this was my motivation to start using monitoring an IV. And the second patient, that was also my motivation. It was a patient with an ALS, tracheostomized, ventilated 24 hours a day, that was happy of his life. And he decided to move from Toulon to my place to live in an island, which is called Corsica, which is at the south of France. It's a very nice place, but there are not many people knowing ALS on this island. So he told me, can you follow me when I'm there? And it was the only way to follow him. And it worked very well.
It is. I think that's one of the lessons that we've certainly learned, that now at the moment we can't have as much face-to-face contact with our patients. And if we don't have this tool, there is something missing, because there is no way we can get the full picture of what is happening. I think patients, in the best will in the world, sometimes tell you what they think you want to hear, i.e., I'm using my machine all the time, there's no problems, but I feel terrible. And at least if you have some information, you can say, well, actually, you're using your machine for 2 hours, you take it off. I see before you take it off that your mask leaks the whole time. Surely we can do something about this and make you feel better, and at least you know what's going on.
Absolutely. Absolutely. And I think what you say is very important, is that when you use remote monitoring, it has always to be associated with some phone call or discussion or video conference, whatever. But you cannot judge the patient only on this data. At some point, you have to talk to the patient to understand what's going on. And the third step, which is very useful and important, is to be able to change the settings remotely. I don't say that I use it for every patient, for sure not, but in some cases it's very useful.
That's some great tips. Thank you so much for talking to me today.
Thank you, Michelle.